Thanks everybody for coming. You might have been expecting Tony for this. Unfortunately, he's on clinical service, so you've got me instead. You probably haven't met me before. I'm David Antcliffe. I'm one of the co-leads for the SepTiC trial and work quite closely with the trial team. So, um, perfect. Thank you. So, yeah, so this is where we are so far. Um, we've currently got 15 sites open to recruitment, and we've got a handful more in setup. And as of now, we've got 177 patients recruited to the first two arms of the trial, so for the fluid intervention and the diagnostic, and 26 who are in the GM-CSF arm. So recruitment is continuing. Obviously, we're still keen to recruit more sites and recruit more patients. So if you're looking to open, please get in touch, and we'd like to work with you to get that done as quickly as possible. So quick congratulations to Scunthorpe, who've just opened, and also to James Cook, who just recruited their first patient as of yesterday. Well done. We're pleased for every recruit that we get. And as we said, we're still looking for sites to join us, and we're still looking for expressions of interest. So if you're in setup, please send through the documents as soon as you can, just so that it can speed up our end of processing. And if you've got any concerns with any of the issues around site setup, we're all happy to help. Perfect, thanks. So we thought it'd be useful just to go through the screening log review and the common reasons that patients don't get enrolled, and that way we can just think about maximizing our recruitment. So if anybody's got any questions as I work through these, shout out, put your hand up, or put something in the comments. But these are our top five. The most common is that patients have been on the ICU more than 24 hours since their initial ICU admission. Now, that's obviously exclusion to the first two domains, the fluid and the diagnostic, but these patients are still potentially eligible for GM-CSF, where we can recruit up to 5 days. So there are some sites who so far are only open to the first two domains, but if you found that that was going well, I would encourage you to think about opening to the GM-CSF, because that would allow these patients to be eligible. I think our other experience, certainly locally, is often the key to these patients is trying to identify them quickly, either through your clinical teams, or we use our safety briefing as well to make sure we get in early, because it does take a bit of time, doesn't it, to screen them. The other one, which we were slightly surprised is high on our list, is that people are being excluded because they have a source of infection that will require a prolonged course of antibiotics more than 21 days. And this certainly seems to be more common than we would have predicted when we were putting the protocol together. So it's perhaps just worth a little bit of clarification that these are patients with a confirmed infection or a very high index of suspicion that they're going to have something like endocarditis, where irrespective of knowing the pathogen or their inflammatory mediators, they need a prolonged course. This isn't to exclude patients where the clinician says, oh, I'm a bit concerned about this patient, I'm likely to want to give them a long course of antibiotics. It needs to be a diagnosis that would be associated with that longer course. Not expected to stay in the ICU for 2 calendar days. I don't think there's a lot we can do about that other than to think about it quite carefully. And I know certainly when I'm asked this, we sometimes get it wrong, and people often end up being sicker than we first think. And number 4 are those patients not expected to survive 90 days due to their pre-existing chronic disease. And certainly when we first started, this generated a little bit of discussion within our own team. And the key there is it has to be because of their underlying disease. If you've admitted somebody with metastatic cancer and the oncologists are telling you, even with the best care, we don't think this patient will survive 90 days, they're the patients who want to exclude, not those patients who come to the ICU and are so sick the clinicians think there's a high chance they won't survive to 90 days. In a lot of respects, they're the patients we think we might make better with some of these interventions. So just high likelihood of death because of a critical illness isn't a reason for exclusion. And then finally, patients who are neutropenic. And again, there's not a lot we can do about that, I think. So I don't know if anybody's got any questions about those common reasons for screening failure, but we're happy to take those now. If you think of any later, do shout out. We can come back to this if people think of things later. In which case I'll hand over to the rest of the team to take you through the rest of the slides.
Thanks, David. So for the rest of the slides, we'll just be giving a few study reminders. So after our last webinar, there was a request to set up an API forum. So this is the NIHR Associate Principal Investigator Scheme. We've got a few API trainees already signed up for the study, and they thought it might be helpful to have a forum in which they could discuss the scheme and how better to support the sites. So we've set this up for Tuesday, the 11th of February from 10 till 11. And we've already emailed all of our registered APIs and sub-investigators. But if you think that yourself or any of your colleagues might be interested or find it helpful to attend, please do email the SepTiC inbox, as we'd like to encourage as many people to attend, and hopefully this will be quite a helpful forum moving forward for those staff members. We've included a link here. You can also find a link on our website, so the SepTiC trial website. There's a link there on how to apply to be an associate PI. And then we've just got a few data entry reminders and FAQs. So we've got sites in a few different stages. Some of our sites, this is more applicable for those who are already set up and have recruited patients. We've had some recent questions about participant withdrawals and how to enter this onto the database. So we have a separate form, which is called the end of study form. This is the form to be completed if a patient has withdrawn from the study. And as you can see on this screenshot, there are different options for the type of withdrawal. So it's important to clarify, with the patient or the family member, if they are withdrawing from study treatment only, the follow-up, or from all study treatment and follow-up. So if you have a patient who has withdrawn from follow-up but has agreed for us to keep the data, you'll need to document their decision on the end of study form and ensure that all data entry up to the point of withdrawal has been entered. And then if you have a patient who has withdrawn just from treatment only, then again, this should be documented on the end of study form, and you should continue with data entry and the follow-up information. And just as a reminder, as some of our sites are now reaching the day 180 milestone, at day 180, there will need to be a telephone questionnaire conducted with the participants. We do understand that it may not be possible to contact the patients on the first go, so we ask for you to attempt 3 times, and if you're unable to contact the patient after this time, then at least if it's documented, it'll help us understand why the follow-up was missing. And then if the day 180 follow-up is not done, please complete a file note to help us understand, perhaps you weren't able to contact the patient or their family member. And please send a copy of this to the SepTiC trial team. And just another reminder about queries. So we've got a screenshot from the database here. You can find all queries for your site at the top of the database. There's a separate tab. And once you've responded to the query, there's no need to assign it to a specific staff member. Will be able to view all the queries open at your site. So just to check, are there any questions for any of the follow-up or data entry so far? And then, as David's previously discussed, we have been reviewing the screening logs recently, and we just wanted to send a few reminders. So we send sites the follow-up calculator, which includes the randomization log and the screening log. For the screening log, we've provided some drop-down options for reasons why participants may be excluded from the trial. So they're mainly based on our exclusion criteria, but we also give you another option. So we'd just like to request to please use the drop-down options. It helps us categorize reasons for patients not being eligible for the study. And if you do write any free text, please ensure any abbreviations are explained. Sometimes there are quite a lot of abbreviations. It may not help us understand exactly what the patient's medical history was and the reasons they were excluded. A few instances we've had somebody's written not eligible, but again, there could be various reasons that the patient's not eligible. So the more information we can get can really help us understand about our trial's eligibility criteria. And again, if you do select the other option, please do explain the reason. And a few instances we've had that a patient may be under 18. It would be good to just clarify the age of the patient as part of the protocol, patients must be 16 and over to be eligible for the study. So we just want to make sure that all eligible patients are potentially being approached for the trial. And then I will just pass over to my colleague Paulina for a few reminders about samples.
Yes, we'd just like to remind you all to check your kit levels and send an email to the SepTiC Imperial team if you'd like any more test tubes, or if any test tubes have passed their expiry date. And also please make sure to check the expiry date when you are collecting samples from patients. And we've had a recent uptick of a couple of the sample shipping forms missing the patient ID and the year of birth. So if you could please make sure to complete those appropriately, just to save us going back and forth to confirm if the correct sample shipping form has been attached to the samples. And also just a reminder to make sure your data entry is completed within 2 weeks of the data visit.
Thanks, Paulina. I'll just set this next slide. So I'll pass over to Janice.
Sorry. Yeah, thanks, guys. So that's the end of our sort of pre-organized slides. So if we can open up now to any other questions, but just to mention, at the moment we don't have a calendar of events for the year for our webinars, so we're quite keen to keep these going month to month. But we'd like to hear from you as to what you would like to see. So is there a particular topic you would like us to focus on? You know, would you like to hear from a particular collaborator, or are there any we encourage sites to participate too. So if you feel that you're running the trial quite well, or you've had some incredible learnings that you'd like to share, then we encourage you to present too. I know that we've already had a volunteer from one of our sites that they'd like to present at one of these webinars. So we're just trying to organise a particular time frame for them. But yeah, just let us know if you'd like to present, or if you have a particular topic you'd like us to focus on. We'd like to hear from you, and then it will help us schedule in a calendar for the rest of the year. Similarly, just let us know what you've enjoyed so far, maybe, or what you'd like us to maybe touch on again. So something that we've already presented, maybe that you'd like to hear a bit more about. But equally, open to questions now. So if you have any other questions you'd like to ask us, please do either raise your hand or speak up, or, oh, here's our Tony.
I just wonder whether it'd be useful for us to sort of operationalize and talk about, for the benefit of sites, about the approach to excluding people on the basis of maybe not being in critical care in 2 calendar days. I think, as sort of David's alluded to, it's a bit of a guess. well, it's a lot of a guess. I think a lot of sites have issues over flow and discharge from critical care, which may mean that out of necessity, patients are staying for 2 days, even if they don't actually require critical care specific interventions. And I guess my view is that I would rather have a patient in than miss them and get it wrong and then be discharged within that 48-hour time frame. I guess my sort of general view of to trying to make it as objective as possible is that if anybody is in receipt of something that we'd regard as organ support, so blood pressure support, renal replacement therapy, or being ventilated, I would suggest that they would all likely be in for 2 calendar days. I guess we can argue about where the cut point falls for how much noradrenaline they're on, but we could take a view that any is enough, but certainly in excess of 0.1 mics per kilo per minute. And then obviously there's other patients who would fulfill the kind of definition of organ dysfunction and therefore being treated for suspected sepsis that might not have those interventions delivered, and then you might decide to exclude those. But again, I'd err on the side of including them rather than not.
Yeah, I think, and what might be a good sort of option there is maybe presenting some scenarios. So for each of those, say, high exclusion reasons, provide scenarios in each of those to sort of maybe explain how they could be included or in what sort of situation they could be included, just to help people understand on the ground. Because you're right, just looking at the listing, it seems like it's quite easy to say, no, that's not the case for this particular patient. But when you think about it as in a holistic view and think about all the other, like say organ support, all the other factors, we could have some sort of simple rules for each maybe that might help people along. Good suggestion. I'm making note of that. Yep. Anything else from anybody else? Any other questions or suggestions for future sessions or anything you'd like to know more about? Okay. Is anyone on from James Cook?
Yeah, I think Jess.
Yeah, I saw Jess come in. Just want to say you were congratulated early on, Jess. I don't know if you joined the whole session, but you were on our first slide for James Cook, recruiting your first patient.
Can you hear me?
Yeah, hey.
Oh, hiya. Sorry. I was just out. The reason why I'm late is I was just commencing day 2 with our patient and the consultant, so apologies.
No, that's very well understood. Well done. Did everything go okay yesterday?
Yeah, it was great. A big shout out to Promi for helping us with the randomization. We'd have been lost without her, so thank you.
Oh, well done. So hopefully the floodgates are open now and you've had your little trial run and everything will become nice and smooth.
Fingers crossed.
Great. Is there anything else that the team want to mention or flag to our sites whilst we have them here?
Not that I can think of. I think we've run through the main study updates. Yeah, I think Kettering General may be helping to present at the next webinar. I think they're a little bit low staff, so I think that's why Anna might not have been able to join, but we'll follow up. But we're still open for any other sites to come and join and help us with the next webinar.
Yeah, so the Imperial team presented early on in the trial, just in terms of how they recruited on the ground, and I think that was quite well received from all sites. So I think it's always nice for sites to sort of share their sort of processes with other sites, just in case there are some learnings and people can simplify how their processes run on the ground. So I think it's always nice to hear how the sites are getting on with the trial, so we can hopefully pop some of those in. And if you do think of anything else that you'd like us to cover, feel free to send us an email or send us any requests